I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Public comment. Seeing none, hearing none, we'll move on to the consent agenda. Have you had a chance to read the minutes? And Shereen, you could probably move down closer if you really wanted to.
Say you
I
don't
know
want.
we got
you
social
don't want it.
distancing working here, but.
I so move we approve the consent agenda as presented. As reading.
Okay, well, I'll,
511.
I apologize for not getting it to you soon.
I did read the minutes too. That looked good to me. Shereen,
I'll
please.
second.
Okay. Moved and seconded to approve the consent agenda as presented. All in favor?
Aye.
Passes unanimously. I don't know where Ken is tonight, but John Shine had said he was not going to be able to attend, something about some wedding anniversary or some such stuff, so.
Important.
Yeah. So he's not here. Next item on the agenda, Cheryl, with the 2020, September 2020 reports. And I did get those at also 5:12 or so. I appreciate it. I know things are tough going forward in Kronos and
Things have been very tough. Can you put that on?
Yes.
Thank you. I'll probably do some more. Yes, so this is a report for September. This is the second month that we have basically been a full month of Cerner. So there's still a lot of learning going on. And of course, we in the finance and the business office are always at the tail end because all those guys had to learn all those stuff up front, but now we're just having to learn and find what's wrong. And usually you have to wait for it to kind of pop out, shake out. So also we went live with Kronos in September, and that created its own set of challenges. We had a lot of problems with getting our PTO accruals to work, and that was really the main reason why you didn't get financials very much sooner. What I would like to say is I feel like for the most part, we're getting it together. It feels like we've got it figured out. I feel like the financials are accurate now. I feel a little more secure than I felt the last few months about things are actually working and I understand them and I can prove it and, be comfortable with the numbers. So, the one thing that isn't working especially well is statistics yet. So I'm missing a lot of numbers. I'm missing lab, radiology, and rehab. A lot of those numbers are just not coming through. And we're working on that. I was told we'd have a solution, but we don't have it yet. So I'll get back to you on that. Hospital numbers, we had a better month in September. I mean, we had 38 hospital patients. We had 255 in the emergency room. That's the main reason why it kind of went up to 330. The thing I guess I'd point out is that our average, what we would really expect to see is about 32 patients in the hospital. So the hospital was quite busy given that average. Emergency patients are usually closer to 280, so you can see that it continues to be slow. Surgical inpatients, we usually see about 6, so August, September were pretty slow. Surgical outpatients, we would expect to see about 32. So these months were pretty low, but we're getting closer here. Swing bed patients, our average is 8, so these are just fine numbers. We are definitely seeing an improvement in numbers in the health clinic, as well as Altura's health clinic, and we're seeing a continued slowdown in the wellness clinic. So, let's see. Okay, our monthly gross patient charges, 3.87 million. last month 2.83, 3.7, we have a flat line right there. Looks pretty good on this chart, but this is about 400,000 short of where we need it to be, short of budget. Our collections on accounts receivable were 2.37 million in October. In September, the month we're really talking about, they were 2 million. Hopefully this is gonna be our low point in August, and we're just gonna keep going up from here. Remember, this is very expected with the Cerner transition. We expected a huge dip. Yes?
Okay, so you gave us the cash flow analysis,
Yeah,
and, November collections look like they're gonna really stink at $1.3 million,
so that was our previous projection,
okay?
but that's not gonna happen.
So
I can't believe that will happen, but that's what we previously projected.
1.3 million on patient collections.
Mhm.
Next month in December, you have 5.5 million,
Right,
and 4.8,
so we based that on Cerner's projections, right?
okay.
So they said a huge deep dive and then a big climb. Well, you know you gotta make up the money you didn't collect.
Well, I hope so, yes.
Right, so no, I don't think I think we're gonna see a much flatter line, we
You think
don't
it's
have
gonna
that
be
big
upward
dip,
of 2 to 3 million
No.
collections?
no. So, but that was what was published in our budget,
Okay.
so I could change it, I mean.
Well, no, I know, change it, but these are projections that, the flat
The
projection
first
is
3 months are-
3.2 million.
The first 3 months are actual,
Right, I got it.
the rest are as originally projected when we did our budget for the year.
So
Maybe what would be
I
helpful,
recall the projection being a flat monthly
We
stream.
used to do it that way, but we really changed it because of the Cerner.
Okay, I guess I didn't see that one, so.
So, yeah, we
That's
pretty much typically used to do it that way, but because Cerner said, look, your cash flow is gonna come to a screeching halt.
I understand that. So the cash flow in November, you're saying is gonna be 1.3 million in collections?
No, I don't think that.
Okay,
That's what was projected back when, right?
you expect it to be something north of that,
Right,
okay.
one of
Oh,
the things that we could do is show you what we use as the original projection as the budget and then try where we think it is now.
Yeah, I look at this being more of a living document, you kind of adjust the.
well, I can make a living document, I guess what concerns me is I can do whatever you guys want me to do, but I don't wanna have like 18 versions where someone says, but you said on this day that this would happen. Because it probably did say that, but I don't know,
Okay, well, I'll try not to yell at you.
I'm sorry. I'll do what you want me to do.
Okay, I just,
I thought about that and I thought, no, it's not gonna be 1.3 in November and it's not gonna be 5 in December.
every month I would expect this to change.
Okay, I will change
That's
it
what,
every month.
and just projecting going forward, that's all.
Okay, I will begin to do that.
Okay. And I won't yell at you if it changes month to month.
Okay, alright. I think we're done with this slide. The days cash on hand is at 65. We need it to be at 90. One of the other things that I handed you guys on the back side of that form I gave you, I didn't mean to print it double-sided, but I did, so there you go. Is our bond covenants, and I did a couple of what-ifs for you, because there's some really big what-ifs as far as CARES money. They came out with, if you remember a few months ago, they said you could keep the money, go ahead and record it, life was great, so we did. And then a month ago, they said, oh no, I think you're gonna need to give that back. If your loss this year is not as bad as it was last year, you're gonna have to give us all our money back. And then they said, well, no, maybe that's not what we're gonna do. We're gonna say based on your patient, your operating income. If it's worse than last year, then you're gonna have to give it back. So a lot of bigger hospitals are yelling really loudly. A lot of hospitals are very stressed. So,
You can
I don't
expect
think that's gonna
a
happen.
change in the SBA PPP program, Senator
think we
Grass, the payroll protection
You
plan.
think it's gonna change?
For my for-profits, for sure. I think it's gonna be all forgiven though. Very
For
very
us? Yeah, that's what I thought too.
sure. Senator Grassley has another bill, Senate bill, whatever. Hopefully they'll get to it in December after all the food gets done up there. We have new Senate. And I think we'll have something before the year end on the payroll protection plan.
That will change from what we know now.
For the hospital, I think we're safe. For my other clients, that's what happened.
Well, we have the CARES money that it appears we're gonna have to give at least a couple $1 million back if nothing were to change from what we know today. Hopefully it will change, but on the other hand, we've also been invited to apply for more money, which we're doing. I don't know if we'll get it, I don't know if we can keep it, I mean, it's just hard to say. So this is based on the CARES money being in our cash, but this does not include the SBA money or the Medicare advance payments. But this sheet does give you some idea of how this will change if, based on some of those assumptions. Okay.
We won't hold your toes to the fire this week.
Well, big changes. I mean, it's hard when the changes are in the millions of dollars. Okay, so then our profit and loss for the month of September, you can see that our net revenue is running at 3,123. It was 2.9 in September. We really needed, year to date, we're at 8.9. We budgeted to be at 9.77. So we are $820,000 short of net revenue based on our budget. Our wages are very close to, page of here, wages. We broke the wages down, benefits, accrued PTO, total wages are very close to budget, which is almost crazy. Contract labor is terrible, but at least it's close to budget. And supply expenses are very high, and this has a lot to do with, one, getting the EMS. We can really forward load the budget for EMS and COVID boarding expenses, I call it. So then our net loss for the year is $626,000 at this point. Our loss last year at this time was $300,000, so that means that of this money, we can take $300,000 out of our CARES and keep it, because it's all based on those losses, so. I'm sorry, I guess I'm looking for good things in the $600,000 loss, but that's what I got. Let's see. Our balance sheet really didn't change month to month. I mean, our cash has gone down a little bit and our AR went up a little bit and really nothing else changed. All right, other questions on, I'm sure you probably have more questions when you have the chance to actually look at the spreadsheet I sent you.
Well, I mean, you're doing the best you can with what you got, so
Yeah,
appreciate
it's
the effort.
it has been a challenge. And a lot of this I had to do manually because it still is really not coming out of the system the way I needed to.
Is everybody healthy in your office now? Are they back to work?
Tasha came back on Monday, and
Okay.
that was a huge contributor to getting the financials out by this afternoon at 5 o'clock.
Well, good.
We're still working on the audit, we're still working on the cost report and the long-term care cost report, so what else are we doing? I can't think of anything else.
Well, tell Tasha we're glad to have her back.
Oh, we are glad to have her back. So do we, is Goose Lake next, should I just go ahead with that? I think it is.
Yep, go ahead for the.
So, Goose Lake. We've kind of seen in long-term care, we have about 20 patients, in assisted living, we're at 9. Revenues have been kind of steady in the long-term care, and they bumped a little bit in September, but I have a feeling it was probably a movement of revenue between months there. Our months have been very steady for net revenue. This month was 260. Really, this whole thing is just kind of steady. Loss is 164.80 and 178. So year to date, 512. We only have, we have several empty beds, and that's just not doing us any good.
But allocated expense, that's the one I had the question on for September was 52,000, been running about 5, so what have we got going on there?
It was 50,000 in July, and I don't remember, but I can find out for you and get back to you. It's what?
The allocated expense in September, when I was looking at 52,378.
Oh,
Yeah, there,
I was looking here, I'm sorry.
there, that one.
I do not know,
Okay,
but I will find out,
thank you.
yeah. Maybe some, maintenance of some sort. Do you have an idea? What went on over there in September?
Anything to do with the lighting?
I don't know, we're all staying far away from long-term care, not allowed to enter the.
We don't account for, we haven't paid for lighting yet. Because the contracts with, the way the money is gonna work is it's all gonna flow to the company that, actually bought the lights. They'll get the money from the, energy trust and will pay the difference. So, that, we're getting it bit by bit, but I don't think we're paying that.
Well, and I think it should be a capital item because of the size of it, and the hospital owns the building, so Lakeview Gardens probably won't see any impact of that at all.
I'm struggling trying to think what that might be, but
Yeah.
It's like we just look at the category where we had other changes.
Well, it's possible.
but we just need to get, we'll get to
I'll
that.
look it up.
Thank you.
I will look it up. Okay. Any other questions? Okay,
Appreciate your effort, Cheryl.
thank you. Okay.
Okay. Any other questions there? We'll move ahead to recruitment discussion.
How is everyone doing?
Good.
Good. So I wanted to talk to you a little bit about recruitment, and I want to cover some main areas to recruitment. First, let me give you the list of open positions that we have. We'll pass this along. And they range from full-time, part-time PRN in just about every department that we have. Right now, it's about 34 to 36 open positions, with the majority of them being full-time and part-time. There are 4 main areas to recruitment that we always look at. First, the industry. And right now, as was projected, I will never forget this, my business teacher telling me that in the 2020s, there would be a healthcare worker shortage. And I thought, well, gosh, I'll be an old woman by then, what will that matter, you know? I didn't calculate that I would not be an old woman at that time.
You're only 29 now.
I am only 29. And so anyway, come to fruition, she was right, there's a global healthcare shortage. So with that said, we have some things to look at as to how do we overcome that, if at all possible. We look at searching, we look at current inducements for prospective employees, we look at barriers to hire, and then we look at what are the solutions to those problems. And so when I look at how we search now, we search very similar to all other critical access hospitals and hospitals actually of all levels. We search through newspapers and Facebook and websites, and then the usual virtual job boards. But one thing that I have found that has had a little bit of life to it is recruiting through the junior high and high school. And I think back earlier this spring, I mentioned that to you all, that making relationships with the local counselors at the junior high and high school. And I know right now some of those kids do come to the facility and they do meet some of the folks here in the areas that they're interested in. But I think it's also important that once we get to a point where COVID is receding and we're not so stretched, we need to actually make a presentation out in public to the public school districts with key staff, working jobs that we need filled, RNs, LPNs, people in the billing department, and explain how interesting and exciting it is to work in healthcare and see if we can't get some of the local schools, kids interested. Some of the other things that we do that has worked in the past is go to the Midwest and South and physically recruit there. Right now during the pandemic, that is almost impossible to do. A lot of these facilities aren't allowing that. However, they are allowing virtual career fairs. We have been partaking in some of those. We haven't received anyone yet, but I'm hopeful that that will be something that will work out in the future. The other thing that works is working with recruitment staff. And I have been working with a couple of different recruitment companies. They're very similar to the companies that Charlie works with to recruit positions. We have had quite a bit of success with them. We do get temporary hires from those recruiting staff companies too. And that's also helpful, and sometimes we're able to convince those people to become permanent with us. So that's kind of how we search in a nutshell. Now the current inducements for prospective employees in the area. We pay pretty darn good wages here, and that's something to be proud of. We also have really fantastic benefits. When you look at some of the benefits at other places, you're looking at $5,000, $6,000, $7,000 for a deductible, and you're looking at $500, $600 a month in premiums. And that's really hard on a family. It's really hard on someone who is working in a labor-intensive department where they don't make as much money. So I'm really proud of our benefits as well as the wages. And something else that's great about here is our quality of life. It is a beautiful area, and it is an area full of friendly people and lots of opportunity. And that makes for a great offering or inducement when we are talking to people about coming here. There's recreational opportunities, there's great school. I love the fact that the school district has this fantastic scholarship program. There are also plenty of opportunities in the area for growth with other organizations such as Red Rock. So when I look at that and I look at how welcoming we are here, and I've been here 11 months now, and for almost 11 months, and I feel like I can speak with knowledge and authority that this is a place that people should want to come to work. But we have to make that so. And one of the things that we have to do is we have to tackle these barriers to hire. And some of the glaring barriers to hire is something I need your help on. And the biggest one is housing options. And I see some smiles and nods. I will tell you that we've gotten candidates all the way to the door, and they've fallen in love with the facility or with the prospective team or with whatever we have to offer in benefits and wages, but they can't find a place to live. And I have someone pretty special in my office, Holly, who is the secret, what do I want to say? Real estate agent, yeah, secret real estate agent for us. And man, if she can't find it, it's not out there. And she does everything, turns up rocks and runs over hill and dale and makes a list, and she's constantly reaching out to people, and she's been able to find a lot of houses that nobody thought was available, but it's not enough. And I need help in getting out the word to people that we need to know if your house is available for rent, or you have an apartment available for rent, or if you are willing to maybe offer a house that you've had for sale for a while and hasn't moved up for rent. So that's one of our biggest barriers to enticing people. The other thing about rentals is we've had trouble, people have pets and they want to come with their pets are part of their family, and some of the landlords are not interested in renting, and we all get that. We all understand that there are sometimes some irresponsible pet owners, but there's a whole lot that are responsible, and so when you're putting the word out, if you could also speak to that, we'd appreciate it, because we have lost candidates as well, because they couldn't bring their cat or their dog.
One of the things you do have in Oregon is rent control, and so that's not conducive to developers really wanting to move into the state and do that type of thing.
I see,
Yeah, that's a biggie
I see, I do.
throughout the whole state.
Well, I wasn't aware of that. I know that these are the things that people overwhelmingly grapple with here. The other thing is trying to help their spouses find jobs. And we have been fortunate at times in doing that, but people come as a package deal. And so we always try, we have to be very careful about what questions we ask, but if you ask questions just right, you can find out whether someone has a significant other that will be coming with them, and also what kind of industry that they work in. Of course, if they work in the healthcare industry, we're really quick about trying to advertise what we have here. It's been helpful that some folks, when they have come here, they've gone to work either for some of the ranchers or they've gone to work at Red Rock. That's been positive. But we need more ways to entice the businesses in the area to help us find work for some of these families that come into town. One of the significant barriers, of course, that's come up this year, and I don't know how many times Teresa and I have talked about it, but it's a great heartache to both of us, and that is losing KCC. And so I would like to ask everyone in the community's help and everyone on the board's help to try and find a way to make it so that we can offer courses again locally. We have reached out, I've reached out, I know Teresa has, I know Charlie has. We need to find a way to offer more educational opportunities. That's also an inducement when somebody is moving to town, is there any local college campus? Taking classes online is all well and great, but having access to a classroom is even more important, so for a lot of folks. All is not lost. We have some solution ideas. One is, of course, as I mentioned earlier, networking with area businesses, working with landlords and the chamber, the county commissioners, any city officials to offer access to housing and jobs. Working together through business, chamber, county commissioners to recruit. So in one of the areas I was at, there was a company who was having trouble recruiting. We were having trouble recruiting. We banded together and we were able to find qualified candidates for both industries and to come to town. And that's something that we do right now a little bit with Red Rock and so on, but I'd like to expand that further. Also, there are new talent clouds, which is a new version of job boards out there, advertising, Instagram, auto text, and email campaigns that are effective in a lot of areas, and I think it would be effective here. So that means I would send you out a message and it would ping off and go to all of your friends to let you know that we have these jobs open here. Also, I think it would be important to have a kind of welcome wagon here in town. I I've not met the welcome wagon, and I've been here 11 months. But it does make a difference. So what we do with our various departments when we hire someone is we often get together with that person for a meal, let them know that we're here for them, show them around the area, and that's well and great, but it usually dies down after a few weeks. It's something that would be a great idea if we could band together with all the other facilities and the community and make the person have a welcome wagon experience that long-term. The other thing that would be of great help for us is if at some point we are able to recruit foreign workers as well. We do have quite a community in town of possible Hispanic workers that we may be able to recruit from, as well as right now we are trying to currently look into working with companies that recruit from the Philippines and other areas. So it's kind of an overview of what it's like to recruit, and it's not a single person's job. It's everybody's in the facilities, and everybody's been great about trying to recruit their staff, but it is an all-encompassing community thing. So I'd like to know, what questions do you have in your comments? Yeah.
At one time, do we still have it in place where if you got somebody to go to work for the district, there was some type of a bonus for
Yeah,
that employee? Is that still in effect?
it's still in effect and people love it. We do, and it's a great recruitment tool along with the compensation and benefits package.
And the chamber used to have a breeding committee, not just for hospital, but for anybody moving into the community. Have we reached out to the chamber?
I actually, it's been a long time, it's been probably 3 months was the last time I left a message to speak to somebody at the chamber. And I have not followed up since, it's been a little crazy, so, but I definitely will, yeah. But I definitely will.
Rebecca, one other question up in the category barriers to hire. The last one, limited scholarship opportunities.
Yes,
The board has addressed that to some extent, and we're looking at developing something further. So if there's a specific area or program or something, if maybe you could get together with Charlie to present to the board that maybe there are things that we could overcome in that area.
Yeah, definitely. So we have great opportunities for clinical staff, but there's non-clinical staff that is often looking for scholarships, and the education would help them in their current position. And so that's actually what that's alluding to.
and that kind of goes hand in hand with the KCC having something on campus or.
Yes. Yes, I was really devastated about that, and not only, just for the facility, but, I'm also an instructor, and so I thought I could maybe do some teaching on a weekend or at night and recruit some of those folks to come to work at the facility, and of course that fell flat, so until they open and have an opportunity again, I guess that's the way it be.
Okay, any other questions? Thank you very much.
Thank you.
You're welcome, thank you,
Appreciate to see the effort you're putting in.
thank you.
And it's 36 people full-time, that'll just really fill out the community.
Yes, it will.
Okay, medical staff privileging without Mr. Gallagher here.
Dr. Gallagher is not, some difficult things during this past weekend, so it's been, was not able to attend tonight. But the medical staff did meet and have a recommendation to you. I'm sorry we didn't send this to you in advance, my mistake. 2 reappointments. One is Dr. Eddie Young, who is a cardiologist that does EKGs and Echo Reeds, he's a consulting medical staff. And the other is Brian Mott, who is also a cardiologist. So the two cardiologists, the medical staff has met and voted to approve reappointment. Oh, excuse me, I don't know why they haven't marked his original appointment, but both Dr. Young and Mott have been on the board, or have been on the medical staff in the past. So I would recommend that the board approve these reappointments.
So move.
Is that a second?
I'll second.
Okay. Been moved and seconded to approve the medical staff privileging as presented. All those in favor?
Aye.
Passes unanimously.
Thank you.
Thank you. Teresa, you're up.
Wow, you guys are speedy.
Yeah, make it 5 minutes.
You don't have to hear from me, I don't mind.
We want to.
Yeah,
Well, I think you probably know we had a devastating loss this week. A long-term employee, a long-term ED tech. So she was the one who had been with us the longest, and certainly her loss will be felt throughout the building, felt by our providers as well. So we've been dealing with that. We also have had 2 COVID positive admissions, so we're moving forward. I think we had some dry runs a few months ago, so even though those patients didn't end up being positive, they prepared us for this, so we're more matter of fact about it than we used to be. I guess other things going on. We've been trying hard to fill our sleep lab position. We lost our sleep lab tech. So that has put us back a little bit in sleep lab, but we are fortunate because a lot of sleep labs closed during COVID because of the difficulty doing tests. And so we're fortunate that some techs are applying that lost their jobs. So that part has been good. We've also filled nearly all of our nursing positions for RNs. So we have a rural nurse residency program in progress. It's about 3/4 of the way done. So we're looking forward to having all those nurses out on the floor and decreasing our use of travelers, agency nurses. We've cut it down by half, but of course we like to cut it down altogether. We still struggle with CNAs in acute. Certainly the event this week didn't help. So that's hard because we haven't had any classes going on. So the only CNAs we can hire are the few that just happened to come to town. So that's been a real shortage for a long time in acute. So that's just a bit about, I guess, things that have been going on. I did attend, and as did Carly, the KCC Advisory Board meeting last week. So that program, I'm happy to say, continues to improve and to show some really great progress in the quality of the program. So I think over the long term, our hospital has made that possible. So financially as well as our support, I think they really have turned around that program. So I'm really happy about it. So any questions for me?
Yeah.
Well, what did someone say? He should have he stood up when he should have shut up. I thought that was a good one. Actually, it was a horse.
A horse?
It was a horse, yeah.
That you should see that horse laying down.
As the horse recovered. Thank you, Teresa.
Thank you. I don't hear any questions, so Teresa, thank you very much for coming tonight, sacrificing your home hearth and everything to come down.
Yeah.
Okay, Carly, I think I'll put you on, you're not on the agenda, but you're here and, as I
That's
understand it, you may have a few things to say about the clinic.
Sure, there's a few things going on over there. So we are at the end of week 3 of moving the screening process inside the building. And that seems to be going really well. The screener greeter staff are much more settled. There's less turmoil and turnover in that, it feels like. And that's settling in. We have set up a space in the specialty clinic, one hallway that's that's walled off with a plastic wall, that's working well. We have an outside entrance into that where the symptomatic patients come. So we're now seeing symptomatic patients inside the clinic versus in their vehicles, but it's in an isolated area. And that seems to be going well at this point. The volume is not high, and so for now, that will work, it will work well. If the volume stays kind of at that low medium level, we will do fine. If we end up with a horrible flu season, or if they spike with COVID, we'll have to adjust that procedure. But for now, it's smooth. So that's that part. Cerner, we continue to work out the bugs every week. Susan and her staff have spent a great deal of time with us the last week or so, and kind of helping line out that beginning process now that we know what the end process looks like. So just really collaborating department to department and working that out has been really good. Kind of getting into some of the population health modules with Cheryl. Working on some of the quality measures within Cerner is coming next, now that we have the base day-to-day stuff happening. And then Karen continues to work with the MA staff. We have 3 more MAs doing their certification test at the end of the month. So we just continue to grow that staff over there and support them in their personal growth. And I will knock on wood, but one department that feels pretty stable is mine as far as, staff and not many open positions right now, and it feels like it's running pretty well, so.
I noticed when I go in, this was a week and then another week, check-in procedure going through Cerner is very drawn out.
Very drawn out.
And they're bopping back and forth between clinical and Cerner and CPSI, and it's you sit there a long time as they go through this protracted check-in. Now I know that Cerner is not populated with past data.
Not much.
Is there light at the end of the tunnel on that one? Are they gonna be able to get checked in a little bit faster?
I think they'll get better with it. I think there is light at the end of the tunnel. Part of why having Susan over there this week is trying to help streamline some of those processes. Each time we see, a patient for the second, third, fourth time, I'm hopeful that that's gonna continue to get better as we have more info into the system. Hearing you say that you are that third, fourth, fifth patient,
That is correct.
time, and it's not getting much smoother. So I hope there's light at the end of the tunnel. That's what we are continuously told. The more information the more that's there, the easier it gets. But it's still a long drawn out process for sure.
I don't want to be the next one in line either. It's tough going into the right now, but that's.
It is. They would say the same thing to me. I don't know if you have to add to that, Susan.
I think it will begin to get easier. We worked through a lot of troubleshooting with them, things that they were doing that was making that process harder for them. So as we said, here's a tip, here's a trick, let's get some of that refined a little bit. I think they're gonna become more comfortable. They know now that they have additional resources they can reach out to. If they have a problem, this is who you tell, this is how we get it fixed. We need a screenshot and then we can recreate it and help fix it. So I think they're going already, just in the 3 days that I spent with them, I felt that much more confident today than they were when I was there on Monday. So I think having that little bit of extra training and just opportunity being there and helping them work through things is making them more confident and not questioning themselves as much. So also, when they tell us there's issues, then we're able to get tickets open and have Cerner resolve things. So, but we don't know that if they don't tell us. So we really opened up that communication this week.
Okay. Thank
Hopefully.
you, I appreciate it. Yeah. Okay, any other questions?
As far as retrieving information, patient like myself wanting to know, did I have this shingle shot, et cetera, is there anything in place that's easy or you can get to? I haven't been able to find anything that has that information online for me yet, if that's called.
Like from the patient portal?
Yeah.
I honestly don't know that, Gerald, what all you have access to there. I would hope that we can get it to where we can have that for you to be able to see, but I think a lot of that's still in eClinical and
Okay, so you have to use the old eClinical patient portal to get to your documents. It's not in Cerner yet.
So,
yeah, it's not.
So it's a matter of populating from eClinical to Cerner, those type of things, and CPSI from the hospitals.
Yeah.
So if you want to see something, you go into eClinical portal or the hospital portal but not Cerner, because Cerner will only have your current stuff.
So we can ask our IT team as well, but we're getting ready to launch on the final testing phase of the archival system, which is actually embedded within Cerner. They can click on a button, it takes them right out to that. I don't know whether that will be available via the portal, but much of the very pertinent information that was in your CPSI and your clinical charge will be available within Cerner. We needed to finish that migration process and getting all of that uploaded. And so that phobia system will be available, the docs will be able to see all of that. We'll have to double check and find out about anything about patient portal until you just brought that up. But we can ask Stephen about that, but certainly those records are going to become more readily available in the next very short while. They're doing the final testing of that as they get ready to roll it out.
Which leads me to the question, how long will the eClinical portal be open for us mortals and CPSI? How much longer will those be open?
I can certainly possible, but I don't know about CPSI.
Yeah, because it's in phases, but it's not more than 6 months.
Okay.
February.
Well, I've been downloading my stuff and printing it out anyway,
Oh,
so
yeah, no,
I'm just that kind of type.
And it doesn't, you can always request anything from your medical record from our medical records department. That information has not gone away, we are continuing to maintain it. Always available.
Okay, thank you. Yep. Okay. Anything else? We've got CEO report.
Well, it's been an interesting couple of weeks with Jen taking a health visit elsewhere. So lots of things that were being done, like getting the minutes out to you, the agenda out to you. Sometimes I get to them like this afternoon, but not last week. So a couple things that have been going on. First off, as you may or may not know, Lake County is now on the watch list, has been put back on the watch list. And the reason for it is we have had changed their rules on they being Oregon Health Authority and what determines the likelihood of being put on the watch list. Part of that is number of cases, but also cases of positive testing patients who are not from a definable event. So we've had two fairly definable events that increased our volume this past week. One was a birthday party, and 11 people tested positive out of that birthday party. Another was there was, after fighting the fires, some of the crew people came back, not sure where they were exposed to it, but they had tested positive. They weren't admitted to the hospital. Any of these had been admitted to the hospital. But they are adding to our numbers, and of course, that impacts us. The last part that impacted us in terms of being on the watch list is an individual who we didn't have any good reason why they tested positive. They had symptoms, we tested them. But it wasn't related to that birthday party or some other event. So the state is looking at spread within the community that's not affiliated with a specific event. And the percentage of positive cases per population. And since we're such a small population in Potomac County, that's what puts us on the watch list. Is that a great concern? No. Are we going to go into more restrictions, lockdowns, that kind of thing? It might change if we got many more cases. The fact that we have finally had some patients that have been admitted to the hospital for COVID, that is a new phenomenon for us. In the past, most everyone that has tested positive has been self-isolating at home. And again, keep in mind, from when a person tests positive, they have 14 days from when all of that's changing, about 10 days, 14 days from when they've tested positive and have had no symptoms. They are then now no longer on the active list. And then for the next 60 days, they are on the, they're still not recovered, but at the end of 75 days, if they have not had any symptoms, they're considered recovered. So these are active cases that we're dealing with right now. It's a convoluted process. And of course, for us, some of our patients that test positive, they don't show up on our lists because they may be from out of county or out of state. And we still test them. We have adequate testing, a fair amount of them. One of the things that impacts us based on this being on this frequency being on the watch list means that now employees have to be tested twice a week when they go to the long-term care. Because again, that's our most vulnerable population. So we are complying with that. We have some special testing. We find after an extended time period, have an agreement that was presented to me early this week from St. Charles that allows us as an organization to accept their credentialing agreement, their credentialing of their practitioners, specifically for cardiology. Now, to put this into context, I think we've been working on getting the St. Charles Medical Group cardiologists to read our EKGs for upwards of 2 to 3 years. First, we had to get the technology to work. So our EKG equipment is different from what St. Charles system uses, different manufacturers. Still does the same thing, but we like our system. We had to get an interface and to figure out how to make that work. We finally, this summer, got that to work between the two organizations. Then, in the normal credentialing, an applicant would send just like you saw tonight, their file, and we would go through and do primary source credentialing on that practitioner. Actually, we don't do it, we hire a company called Coitman, that happens to be based in Denver, to do our primary source credentialing. That information goes to the medical staff. The medical staff reviews it. If they say that's fine, it gets presented to you, and you get final approval. What our agreement with St. Charles allows is for us to accept the credentialing process done by St. Charles system of those specialists, because it's predominantly specialists. That saves us money and it saves us time. They agreed to the agreement in early May, June, and then had second thoughts. Because one of the components of credentialing is that it is a rigorous process that physicians are do within themselves, within their professional colleague relationships. And that information is protected information. And if St. Charles were to give us their credentialing information, that would expose them, their physicians, to that credentialing process, and it would no longer be confidential. We know it would be no longer be privileged. So we settled on a resolution of an either up or down decision. We don't need to know the specifics of why somebody may or may not have been approved. It's easy if they're always approved. It's more difficult when there's someone who may be having to do additional education or have to do some, or may lose some privilege. Finally got that agreement. So after we finish the details at the next board meeting, I'll bring you a copy of the agreement. Now, we got past that because we couldn't wait, and we actually credentialed the cardiologist. You see that. So they're reading the EKGs right now. But this agreement allows us to make it much smoother for all of the cardiologists, not just the few that we approved. So I'm pleased that that is moving along. It's been slow. We've made some significant progress, as you heard from Troy Armstrong, in our EMS services. A couple things that we have recently done. I think you are aware of this. We purchased a new chase vehicle. It's a Tahoe, and it arrived on Monday. The company that we bought it from in Illinois couldn't seem to find Lakeview on the map and delivered it to Bend. So Troy had to go up to Bend to bring it back. I don't know why they couldn't find Lakeview, but these things happen. They have a Lakeview, Illinois. We now have and in order for it to be licensed, it has to have our insignias and decals on the vehicle. Those are now there. So that's an exciting addition, because that'll allow, if there is, whenever a team goes out, they may not have all the tools, and rather than send a second ambulance, just to bring some additional either members to help in the incident or additional equipment. Now with that chase vehicle, it can work much better. Secondly, we have signed an agreement to purchase, and that by the way, that was budgeted, as is additional ambulance. So we are purchasing that. It was a budget item. We are slightly under budget, so that's a positive. But who knows? At the end of the day, we'd like to get to where we budgeted, and we are hoping that that will be here in December sometime. What that will allow us to do is have a newer vehicle act as one of the ambulances that we would be using, and one of the older Lakeview disaster units as our transportation vehicle, allowing us to do inter-facility transport. That will be a huge benefit, especially with weather delays. Next, we have selected software. Troy talked a little bit about this, but we need to have electronic record that the ambulance crew is using when they're on site. And they've selected software, and they will go live in January with it. So it has gone through the Lakeview Disaster Unit. They've all had input on all of these items. And so Troy's been really good at working with the disaster unit, and they've been very supportive of finding ways to have all eyes look at it and get the best solutions for it. So it's very positive. Lastly, there was whenever we have Halloween, we like to try and make it fun for kids. Trunk or treat was not recommended by the state because of the difficulties, but they did discover that PVC pipe and sliding candy down along 8 and 10 foot PVC pipe worked pretty well. And so we provided candy to about 300 people in the parking lot between Jerry's and Safeway on Halloween. We also had the same kind of thing for our long-term care, where they were able to use PVC pipes, and some of our residents were able to pass out candy. We had about 60 people there. So that was all wearing masks, all safe, but everyone, I think, had a good time. So that's a wonderful thing.
I took my grandkids there, so I thank you for the candy.
It was our pleasure. I hope they were wound for sound for a long time. We have been looking into the possibility of changing our health insurance benefits for employees. As you know, one of the big items that we have as an expense is it's a great benefit, as Rebecca said. It is helpful for recruiting and for keeping staff. It is also very, very expensive. So we have been looking at alternatives. And I hope today that I would be able to provide you with some alternatives. And unfortunately, I don't have that option. The couple of organizations that I talked to about that were not yet able to come up with quotes and pricing that would meet what we currently have. So I may find something before December. If not, we will revisit the issue next summer. So I apologize for not having good results, but I think it is.
That's an important subject, and I think we shouldn't rush it, so.
I felt that they had ample time to provide us with good estimates. I have yet to get the information that I was expecting. So, other than that, it's been kind of a slow time.
One quick question on our housing up in Christmas Valley, how are we doing there?
I think we would probably like to talk about that in the executive session.
Okay.
I can say that this in public session, that we have been given notice by the county commissioners that we need to vacate the annex where we have public health and mental health.
I was just wondering what the timing on that was.
So originally they thought that we could move out within 30 days. And I told them I didn't have a good option at that time. A complicating factor to that is we also have space in North Lake Health District's building. You recall several times we've had some issues about what the agreement is and what our rent would be and how that facility would work. So the North Lake Health District owns the building that they rent to several different healthcare providers, but also to the Pine Health Clinic. And the Pine Health Clinic secured financing and they're buying the building from the North Lake Health District. So that is a great benefit to the Pine Health Clinic and frankly to the community, because that assures the community that the Pine Health Clinic will continue to stay in that building for extended time. What it does do is it complicates our need to move out of the ends. Because part of the conversation was talking with the North Lake Health District, would they add on to accommodate our needs? So I don't have a clear answer on when we would have to vacate the space because I don't have another indication. And I can talk about it this morning.
Thank you.
Other questions?
Okay. Hearing no other questions, we will adjourn. We'll go to executive session under ORS 192-660, bracket 2, bracket A, personnel, bracket C, medical staff, record deed real estate and record deed legal. So, regular session is adjourned, we're going to examine.